Hey everybody, I'm Maggie and we're back on SRH Access Facebook Live. Today we're here with our director of our hand center, Dr. Scott Oishi. We're really excited to have you back. You were on a couple months ago. And today we're going to talk all about our hand services here, our hand and upper extremity services that we provide our patients. So today, let's get started. What is the services you provide for our hand patients?
Well, it's interesting because we call it the hand service, but basically we treat conditions all the way from the neck, the nerves in the neck, all the way down to the hand, as well as a lot of the problems in the feet, and also reconstructive problems, whether it's in the back or all over the body. So we're much more than just the so-called quote hand, quote, end quote service.
That's awesome. I mean, it's good because I think people kind of get a little confused because I know we have our whole orthopedic system, it's broken up by these centers. And so the center for the hand, you were saying is kind of broken up, has the upper extremity. What is kind of that goes into the center? I know we have research and education, and what is that the hand center's doing to really improve that part of it?
Well, for us, the children that come in with congenital hand differences or whatever they come in with, it's trauma or some sort of reconstructive problem, they need much more than just myself or Dr. Stutz to see them. So we have a very comprehensive approach in that we have nurses that are very well educated. We have therapists who also see them at the same time. We have child life services, even child psychologists on board. So it's a very sort of comprehensive approach to these children because they go from the time they're born to the time that they're 18 years old. And their needs, as well as what they expect, change during that period of time.
Right, as they're growing.
Right.
So let's get into what is the most common conditions that you're seeing kind of day to day, and kind of getting into how they're diagnosed, to the treatment plan, and kind of as they grow up into adults. So let's kind of get into the condition part of it.
Well, what's interesting is the thing that we see the most, they're actually extra digits. The most common is they have extra digits off the one side of the hand by the little finger, and that's very hereditary. Many times we can just treat that in the clinic. There's the second, probably the most thing, is we see kids with trigger thumbs, or kids that have sort of what we call duplicate thumbs, but actually it's abnormal split in thumbs. So they look like they have two thumbs in one hand. Okay. And that's what probably the most common thing, as well as webbed fingers. Okay. Many of these things are not genetic, because the question that parents always want to know is, am I going to pass it on, or are they going to pass it on to their children? So a big thing for us is really counseling of the parents. And for many of the conditions, it's not hereditary, and we can certainly tell them that their next children or the children that they have will not have any more risk than the general population. That being said, we do see some things that come in here, like deficiency on one side of the limb or the other, that can be genetically passed. And many times we're the first ones to see them because, as you can understand, when a child is born with a congenital difference of the upper extremity, many times that's what alerts everybody around them, and they come in to see us within a week of their life. And so our responsibility is not only to make a diagnosis, but also try to check for other things that can be associated with it, whether it's blood problems or skeletal problems or heart conditions or kidney conditions. And so we're responsible, and we take care of all of that, along with the pediatrician, their general pediatrician.
Right. So you were talking about how some of this, as you said, could be happening in their development while they're in the womb, and when they come out, that's when they're coming to us. So how does it? Are our specialists working with pediatricians before the baby is born, if something is detected while they're in the womb, or is it more so after they're born, they come here and diagnosis is made?
Probably both ways, because many times things can be diagnosed with ultrasounds. They're so good now with 3D ultrasounds. But the upper limbs actually grow from 4 to 8 weeks gestation. So believe it or not, 8 weeks into the pregnancy, the arm has grown. And it's formed, and it just grows bigger from then until the delivery, which is 39, 40 weeks. We don't see too much of sort of in utero counseling, it's called. And we mostly see the children when they're born.
Right.
But many times there are issues, and they say, well, when you're born, we'll send you to see them at Scottish Rite Hospital.
Cool. Well, so I think we have some photos that we can show for some of these conditions.
Sure, absolutely.
Okay.
So we wanted to just sort of show you what sort of common conditions are that we see. So this is that sort of condition that we're talking about where children are born with two thumbs, it looks like. People call it duplicate thumbs, but really what it is when the hand is forming, there's an abnormal sort of split in the thumbs. So they end up with two. And besides being sort of a cosmetic issue, it also is a functional issue because sometimes that outer one can get in the way. So we reconstruct them by sort of taking this one off, but also taking structures from that and putting onto the ones that we keep. And so you can come up with a very nice result from it, and very minimal scarring, because there's always an issue of, what's my scar going to look like? Because many parents want to know that. And this is very good for that.
Wow. And I mean, is there a certain age that this is handled when it comes to hand surgery? Are you waiting until they're more functioning with their hands and they're a little bit older? Or, I mean, is it something that they're done when they're babies?
No, the best thing to do is, no matter what you're doing, is if you can wait till they're over a year of age, that's probably the best. I mean, number one, the structures are bigger and you can see them better.
Right.
And number two, the anesthesia risks certainly fall as they get to be a year and a half of age. So we try to wait and push it out there if we can. There certainly are some things that we do before a year's age, but we try to wait.
Okay.
And so, another thing we see quite a bit is the so-called web fingers, or syndactyles, when they're born with these, variable fingers that have the webbing. And this is certainly mostly a sporadic condition, meaning that when the parents come in, the first thing they want to know is, did I do something to cause it? And we can tell them, no, you didn't. It's just sort of, we all are born with, develop with webbed fingers, and towards the end of the forming of your hand, which is 8 weeks, so somewhere in the 6.5, 7 week, there's a signal that goes out to split to make webs, and sometimes that doesn't happen. And the last web to split is the middle ring. Okay. So that's where we see, but we're able to also take something like that and reconstruct it into something like that. So, very little scarring, and functionally does very well.
Right.
And actually can improve them so they can get their fingers out.
Wow.
I think some of the most impressive things that we do is some children are born with either absent thumbs or thumbs that don't work as thumbs. And it's very important, as you can understand, to get around things to use a grasp. And so we actually take the index finger and make it a thumb, called a policization procedure. And so if you look at that, that's after this one that wasn't functional, and this index finger is moved over to be a thumb. And you can see how it basically looks like a thumb. Right. Because we shorten it down, we do certain things to reconstruct it. And, functionally-wise, everyone knows, well, what are you going to do with it functionally? And so this is the child that actually he's had it done on both sides, but he's able to manipulate objects, and you can see he uses his thumb, uses what would be his index finger, but it's his middle finger. In his case, his index finger is a thumb. And this is another case where the child didn't have much of a thumb, and we're able to move his index finger over. So it looks like that. And if you compare them, if you first look at it, you'd be hard-pressed to know that there's not 4 fingers and a thumb on this side. And this finger has 4 fingers. This hand has 4 fingers and a thumb. So it's remarkable. And you say, well, can you do small objects? And you can.
Wow. And I mean, in our therapists, I feel like this, especially this procedure, especially because they really have to learn how to function with that one finger moved to work as a thumb. So, is our therapist really heavy working with these kids and getting them after the surgery and making sure that they can use the
absolutely.
hand?
So our therapists are, we have trained therapists that just do hand rehab. But believe it or not, if you do this surgery before they're about age 6, there's such plasticity in the brain that the kids, when I get to be teenagers, I ask them all, what is that? And they tell me it's their thumb. If you do it later on in life, like they're 9 or 10 or 11, they always tell you, well, that's my index finger, you move over, silly. Right. But when you do that, or they say, that's my thumb, what are you, crazy? Yeah. But there's not much rehab, believe it or not. When they initially come out, it's more the parents are scared of the incisions and having the child move it, so that they're very good about showing them how to exercise it and how to massage the scars. Okay. So, I think that's, for us, is a fantastic procedure, and it's sort of life-changing for them.
Oh, for sure.
Yeah. And some of the complex stuff we do are, some children are born with this thing called a cleft, and it sounds just like it is. In the past, some of it's called lobster claw hands, but cleft hands. And you can see that many times it's not only cosmetic or an aesthetic problem, but it's also functional. You can see how these index fingers are way over the thumb. Right. And so we're able to many times get a pretty good result by sort of closing the web down, which used to be in here, and also making a nice web space for them. And again, it's all about function. So when we look at a child in clinic, there's a lot of things that we can think, okay, we could do that to the child. But really what we want to do is only do it if we're going to do it for the child. So it's not only an aesthetic thing we're going to do. Many times we do that, but most is for function. Right. It's only if we're going to benefit the child long term. And that's, I think, the tenet that runs throughout our whole service, is that we want to do something for the child, not just to them. Right. So, and then we also do some reconstruction after trauma. We also do a lot of trauma too, which I think we'll talk about maybe in a later sort of
yes.
Facebook Live. But sometimes we see sequelae from trauma. Like this child came to us from a long way away in South America, because they found us because we happen to do things when children are injured and they get some injury to their muscle compartments in here, and so basically lose all their muscle that makes their fingers bend. You can see that looks like sort of a lifeless hand. Well, we were able to bring her up here, and because the hospital is just so great and supportive of what we do, that we brought them up there for a few weeks. We were able to take a muscle from the leg and transfer it into here with a microscope. So that's what the microsurgical reconstruction is, and this is her back in. They sent this from South America.
They sent it from home.
Right,
Home
so it's not the it's not the best quality, not like we would get here.
Right.
But you can see now that your fingers are moving, and it's taken sort of a lifeless sort of hand and sort of restored sort of
full
function to what she wants to do, or pretty close to function, because she had no flexion of fingers. Wow. So many of that stuff we're involved with too. And believe it or not, that doesn't need that much rehab.
That's awesome.
They need a little bit to start, but then
they kind of bounce back.
Right.
That's awesome.
I mean, it's just what, we sort of provide that sort of
comprehensive. Well, I think, one of the big things that a lot of parents want to know is kind of the long-term effects, and you were talking about this function and getting their function back. And we actually had a question come through yesterday, and they were talking about a kid who had arthrogryposis. And I know we discussed that in an earlier Facebook Live, and you can maybe explain again kind of the baseline of that. But she's wanting to know, in what ways can you help kids with limited range of motion due to arthrogryposis to participate in activities that require the use of hands, such as a piano or playing sports or stuff like that?
Well, we get a lot of those kids that have what's called amyoplegia, arthrogryposis, and every one of them is different. So, just like this, every child we have to examine and see what their sort of condition is and what their possibilities are to give them motion. Many times we can give them back elbow motion. It may not be active, so they may not have a biceps. They can actually bend their elbow, but they're able to put it against the side to sort of bend their elbow. We can put their wrists in better positions. Many times those children are flexed down, and we actually do a surgery to bring them back into what's called a neutral position. So they can do sort of palm-to-palm activities instead of having to always do cross. I think that helps them a lot. What we can't do is we can't replace sort of the abnormal joints and things that exist in those children. So many times the parents want them to have normal fingers and normal thumb motion. We just can't do that. And so we try to maximize the position that they're in for use. But we very rarely limit them. We tell them to go ahead and try. I may have one of my arthrogryposis children that was playing football.
And they adapt.
And they adapt like incredibly well. But to help that, we actually have our occupational therapist, and we have a great team here that deals with amyoplegia or arthrogryposis. And so they actually, in some severe cases where they don't have very much motion, they actually put them in a hospital, or at least see them on a daily basis for about 3 to 4 days to try to get their activities of daily living better. And independence, because everything you're striving for is when the child gets to be 18 or 20 or whenever they leave the house, is that they're maximally independent for their own life.
Awesome, yeah. I think to kind of finish out today's session, one of the big things with the Center for Excellence is our research that we're doing, and kind of talking about what is it that the Hand Center is really doing to improve with the treatment and care of these upper extremity deformities and these hand conditions through research.
Well, for us, we're very fortunate. We have a wide variety of diagnoses, as well as have many patients with one particular diagnosis, and also a long-term follow-up on these children, because they love coming here to this hospital. I mean, from the park outside to the volunteers, to the popcorn, to everything they get here, it's just so warming. So they all come back. So we're able to have long-term follow-up for these children, which many places don't have. But getting back to your question, so we look at the diagnoses and we see how we treated it, and we've been around for a long time, so we can look at them 10 years after we've done that procedure, because that's the important thing. We don't want to keep circling and doing the same thing we've done if we know it doesn't work. So much of our research is called clinical outcome research. So we take a procedure that we've done, and then we look at it when the kids are skeletally mature or even older to make sure that it's lasting. Number one, it works. Number two, that it's a lasting procedure. And number three, that it's really helped them. And so we do what's called outcome studies. We're interested in basic science. We have these children that have these overgrowth conditions. And right now we're very actively researching ways to not only treat it, but to diagnose what kind of metabolic level they actually have in their limbs. And so that's sort of ongoing basic science research, which I think many places don't have. And we're fortunate that we have fantastic basic science researchers upstairs that help us.
That's awesome. That's great. Well, thank you so much for joining us today. We're really excited to have you. And next week we'll be back to talk more about our hand center and our hand conditions that we treat. So thank you so much for joining us, and we'll see you soon. Thank you.